My topic is around the use of tranexamic acid for haematology patients with thrombocytopenia. And I guess the first question is, why would we be interested in studying tranexamic acid in this patient population? So our current standard of care to prevent bleeding in patients with severe thrombocytopenia is the use of prophylactic platelets. And that's particularly for patients when they're undergoing intensive chemotherapy or stem cell transplantation. But we know from the clinical trials that have been done looking at the effect of platelet transfusions in preventing bleeding, that there still persists high rates of significant bleeding despite the use of prophylactic platelets. And so this is from the TOPS trial, which was published in 2013, which compared a platelet prophylaxis strategy with no platelet prophylaxis in patients undergoing intensive chemotherapy or stem cell transplant. And you can see that even with the use of regular prophylactic platelets, around 43% of the participants had grade WHO, grade 2 or higher bleeding. And the other thing we know is that platelet count itself isn't a great predictor of bleeding risk in haematology patients unless it's very low, so less than 5. And so we need other ways of predicting, which are the patients that are most likely to be at risk of bleeding and may benefit from other interventions. And some secondary analysis have been done of either dose studies of platelets or prophylactic versus no prophylactic platelets. There are some treatment-related factors, some other laboratory factors. I mentioned a platelet count less than 5. A low hematocrit is also associated with bleeding. But what was observed in this analysis was that a platelet transfusion or a red cell transfusion on days with bleeding did not change the risk of a bleeding outcome on following days. So the evidence from the trials of prophylactic platelets suggests that we need alternatives to platelet transfusions to try to reduce this bleeding risk for our haematology patients. And that's important for their outcomes, but it's also important for our blood supply because we do have increasing demands on platelet supply, and haematology patients are the largest single users of platelet transfusions. And this is an article I just Googled yesterday on SBS from September 2 months ago in Australia about the blood service having challenges with meeting current platelet demands, and the similar observations around increasing platelet demands have been seen worldwide. So what's the evidence that tranexamic acid may be beneficial in this setting? Well, we've heard this morning about its use in other clinical settings, including perioperatively and in bleeding patients. There were 2 small randomised control trials that suggested a potential benefit of tranexamic acid that were done in the 1990s and 1980s, but small trials, 56 or 12 patients in those 2 trials. But based on that, tranexamic acid was being used in clinical practice in haematology patients. And the reason why it might be effective is that we know that PAE1 is a key inhibitor of fibrinolysis secreted by platelets, so perhaps in the setting of severe thrombocytopenia, we've got increased fibrinolysis. So that was the background for the design and why we undertook the TREAT trial, which is a trial to evaluate tranexamic acid therapy in thrombocytopenia. So this was a great collaboration between the UK, our colleagues at the UK, the NHS Blood and Transplant, Lisa Escord and Simon Stanworth, and our transfusion research unit here at Monash University with Erica Wood, who's here today as well. And so our trial question was, does TXA given in addition to prophylactic platelets to patients with blood cancers undergoing intensive chemotherapy until platelet recovery or up to 30 days reduce the risk of death or grade 2 or higher bleeding? And so we've presented these results at ASH, and the full publication's pending, but we'll go through the results that we presented at ASH. So it was a randomised, double-blind, placebo-controlled parallel superiority trial. We had 27 sites in the UK and Australia, and we had a target sample size of 616 patients. We included adult patients with blood cancers undergoing intensive chemotherapy or transplant where they were expected to have severe thrombocytopenia of less than 10 for at least 5 days, and the clinicians could predict that based on knowing the intensity of the treatment they were giving for the various blood cancers. We excluded patients with a prior history of arterial or venous thrombosis or veno-occlusive disease, a history of seizures or severe renal impairment. And patients were randomised to TXA 1 gram every 8 hours IV or 1.5 grams every 8 hours orally. And the primary outcome was the proportion of patients who died or had grade 2 or higher bleeding within 30 days. And we had a number of efficacy and safety outcomes, which we'll go through. So we screened and consented and enrolled participants, and then they were randomised once their platelet count was less than 50, because most of the patients were coming in for planned therapy, so they might come in with a normal platelet count, but we expected them to develop severe thrombocytopenia. And then they commenced the allocated treatment once their platelet count was less than 30. And they continued until platelet recovery or up to day 30. The primary outcome included bleeding, so this was done with a daily bleeding assessment from randomisation up to day 30, and done by hospital staff while an inpatient or a patient self-report when an outpatient. And we had done a series of studies and work to work out the best way of measuring bleeding in these patients and develop this bleeding assessment tool to make sure that it could be as objective as possible. So we screened over 1,700 patients, approached 1,200 and consented 636, so approximately half, and randomised 616 as some patients didn't reach the platelet threshold of 50. And 306 were allocated to placebo, 310 to tranexamic acid, and 97% of those patients were included in our modified intention to treat analysis. And the reason why they might not be included in the modified intention to treat were that their platelet count hadn't reached, the most common one was the platelet count hadn't reached 30, which is when the intervention commenced. So our baseline characteristics, the mean age was 55 years. The most common diagnosis was acute myeloid leukemia, but other common diagnoses include lymphoma and myeloma. And the most common treatment plan was either induction or consolidation chemotherapy, followed by autologous stem cell transplant. So this was our primary endpoint. So we didn't see a difference between tranexamic acid and placebo for the proportion of participants who died or had a grade 2 or higher bleeding from day 1 to 30. So that was 31.7% in the tranexamic acid group, 34.2% in placebo, which gave us a hazard ratio of 0.92, but a confidence interval that included 1. This is the breakdown of the bleeding, the highest bleeding grades that participants experienced. So in the blue boxes is no bleeding, green is grade 1, and the orange is grade 2, and on the left is placebo, and here's tranexamic acid, and you can see that the majority of the bleeding events were grade 2, and we only had 6 grade 3 or grade 4 bleeding events across the 2 arms. In terms of our secondary efficacy outcomes, there was a similar time to the experiencing the first WHO grade 2 or higher bleeding. We measured the proportion of participants who required platelet transfusions and also the number of units that they received, and we didn't see any difference in the platelet transfusion requirements between the 2 groups. We did see a difference with red cell transfusion, so participants allocated to tranexamic acid were more likely to survive to 30 days without requiring a red cell transfusion, so 29.4% compared to 20% in the placebo group. But there are a similar number of red cell transfusion units administered to each of the treatment groups. And following on from some of the interest around tranexamic acid in infections, we did measure the number of days with fever, defined as greater than 38.5 Celsius, and we didn't see a difference between the 2 treatment groups for that outcome. All-cause mortality was similar between the 2 treatment groups, so at 30 days, 2.9% in tranexamic acid, 1.1% in placebo, and at 120 days, 8.7% in tranexamic acid and 5.3% in placebo. And we're interested in thrombotic events. We've heard before earlier about the potential association between tranexamic acid and increased VTE risk, particularly if you've got prolonged tranexamic acid, which these patients were on, and they've also got a higher underlying risk given that they've got cancer. But there was a similar proportion of participants who had a thrombotic event between the 2 groups, so 3% in tranexamic acid and 2% in placebo, and similar proportion of patients who experienced veno-occlusive disease. And we also had a similar number of serious adverse events between the 2 treatment groups. We had 2 pre-specified subgroups. So as I mentioned, patients were enrolled and randomised with a platelet count of 50, but some patients, particularly those with acute myeloid leukemia at presentation, may already be thrombocytopenic at the time of enrolling. So we wanted to look at the groups of patients who had a platelet count less than 30 at consent. And that group is on the top. It was a small group. There's only 52 participants in the placebo and 42 in the tranexamic acid group. But the effect estimate actually favoured placebo for those patients, and the test for heterogeneity was significant. And our other subgroup was around treatment compliance. And we did have a significant proportion of patients who decided to discontinue the treatment. So 54 in the placebo group and 73 in the tranexamic acid group. But we didn't see any significant subgroup difference for that, for treatment compliance. So based on our study, we'd say that tranexamic acid, given in addition to prophylactic platelet transfusions to haematology patients undergoing intensive therapy, did not result in a reduction in risk of death or grade 2 or higher bleeding. We did see a higher proportion of patients who survived to day 30 without red cell transfusion with tranexamic acid, and no difference in some of our secondary efficacy endpoints or thrombotic events. So there has been one other study, the American TREAT trial, which was conducted at a similar time as TREAT, and we designed the protocols and they were aligned early so that we would be able to combine results. And ATREAT's been published previously, and a very similar design, a slightly smaller study. They had 165 patients in the tranexamic acid group and 165 in placebo. But again, they found no difference in their primary endpoint of any grade 2 or higher bleeding. And you can see here the proportion of patients with grade 2 or higher bleeding or death, which was our primary endpoint, and the overlapping lines for the ATREAT study. They also had low rates of thrombotic events, so 6 in the TXA group and 9 in the placebo group, but they did observe more line occlusions in the TXA group, 27 versus 11 in placebo. And so when we pool ATREAT with TREAT for the primary endpoint, you can see we have over 870 patients in the pooled analysis. The overall risk ratio is 0.9, but a confidence interval that includes 1. And I guess following on from Beverly's point earlier about having some evidence of why TXA might be effective in this population and whether hyperfibrinolysis is actually present. Well, this was an analysis, and I was hoping that Anton would be here today because he's the first author, but wasn't able to attend due to visa problems. But they had some correlative samples from the ATREAT study, and they found that they didn't see any evidence of hyperfibrinolysis in their baseline samples for the trial participants, which is this group here. And so these down here, observations of those that had a hyperfibrinolysis on their assay, and you can see that only a small number of participants did have hyperfibrinolysis. And they also looked at the association between tranexamic acid levels and bleeding and couldn't see an association there between the level of TXA and the risk of grade 1 or grade 2 or higher bleeding. I think this does raise questions for us for some of our other haematology patients. So these are patients who have come in undergoing intensive chemotherapy with a short duration of bone marrow suppression where we expect them to recover. But we have a lot of patients who have very severe and prolonged chronic thrombocytopenia, and it's associated with a high rate of bleeding and also mortality related to bleeding, and it does impact on their quality of life. We sometimes use prophylactic platelet transfusions, and that's pretty common, I think, at some of our centres in Australia, but there's no evidence that it's effective in these patients, and it's not recommended by our transfusion guidelines. And there are risks of particularly prolonged platelet transfusion, particularly around becoming alloimmunised and refractory to platelet transfusions, which then makes the care for these patients very difficult if they need procedures or do have bleeding. And we do see that tranexamic acid is variably used in these patients as well. And so we've done an audit in Australia, and we've also done a survey in Australia, and around a third of our MDS patients with thrombocytopenia were given either a combination of TXA with platelets or TXA alone, and there's similar data from Canada as well. So I think this is a group that we need to think about what we're going to do with their management. So I'll finish up there and just say, so overall we didn't see evidence that TXA reduced the risk of death or grade 2 or higher bleeding in haematology patients undergoing intensive therapy. It does raise questions where there are still selected patients where we might consider TXA, particularly given that we didn't see any safety concerns except for that subgroup analysis. What's the relevance of these findings to chronic thrombocytopenia? And I guess our need for research into other interventions to address the high burden of bleeding despite prophylactic platelet transfusions. So I'll just finish there and acknowledge all of our investigators across Australia and UK and the other chief investigators from the UK, as I mentioned, Lisa Escott and Simon Stanworth and Erica Wood, and our participants and their families for being a part of the trial. Thank you.